As of now, early 2023, one of the key open questions in managing advanced non-small cell lung cancer is the optimal treatment approach as a first-line therapy for patients whose cancer does not have a driver mutation like EGFR or ALK, and whose cancer expresses high levels of a protein called PD-L1 that is associated with a higher probability of responding well to immune therapy. We define this high PD-L1 as 50% or greater, and that's about 28 to 30% of patients with advanced non-small cell lung cancer. The reason there's controversy is because there are two competing standards of care that are both very reasonable ideas. One is just to do the immunotherapy drug alone. This is called a checkpoint inhibitor. The first of these that was well studied is Keytruda, also known as pembrolizumab, and it was shown to be better than a chemotherapy combination of two drugs several years ago. And we now have years of follow-up that showed that the Keytruda alone is associated with a higher response rate, about a 45% chance of major tumor shrinkage, a longer time before the cancer progresses, and a better survival than chemotherapy alone. There are also a few other immune checkpoint inhibitors that have been shown to produce similar results and are also FDA approved, just not as widely used. There's not a reason to favor them over Keytruda, but they're about the same. And then the other option is an immune checkpoint inhibitor, or sometimes even combinations of immunotherapies with chemotherapy. And so this option has a response rate that is now in the range of about 60% of major tumor shrinkage and good progression-free survival time before the cancer progresses and how well people do. So this leaves us with two competing options of immune therapy, either alone or combined with chemotherapy. And they're both reasonable choices. One is sparing the chemotherapy if we can get away with it, but leaves people with a risk that the cancer will progress and they might have a decline in their performance status that might make them not as strong as we might hope to be able to withstand the potential challenges of chemotherapy, so they might miss that opportunity. On the other hand, if we give everyone the combination of chemo and immunotherapy up front, you can overtreat some people who wouldn't need it and could do very well even for years and years with immunotherapy and really not need the chemotherapy and leave that as a back pocket option for later. Now, this has remained an area of judgment, and there was an FDA review of the data in various trials that has actually shown that the patients who get chemo combined with immunotherapy and have high PD-L1 have a better response rate than with immune therapy alone, and a longer progression-free survival, but not a statistically significant improvement in overall survival, though there is a trend in the favorable direction there. And that has left oncologists really with a lot of judgment or room for judgment about what they might recommend to their patients. And so you can see this as a half empty or half full approach. Some folks who were leaning toward immune therapy alone say, well, there's no difference in survival, so I'm going to recommend the immunotherapy, while other people say, well, the trend is more favorable for the combination of chemo and immunotherapy, and it's a better progression-free survival and response rate with this, so I'm going to favor that approach for most of my patients. There's also plenty of room for individualizing, so that if we have a patient who has a lot of cancer on their scans, maybe an increase in their symptoms every few weeks, whether it's pain or escalating shortness of breath, weight loss, etc., those are patients where we really might want to have the patient get everything up front and maximize the chance for getting control over the cancer early. And in patients who have fewer symptoms, and less extensive disease on their scans, we might be more comfortable giving the lower approach or less intensive approach of immunotherapy and leaving the option of chemotherapy to add later. There's also some data that show that patients who have very high PD-L1 in the range of 90% or higher can have an especially high chance of responding to immunotherapy, and we might want to use that to help factor in a decision. So if a patient has very high PD-L1, being even more confident that immunotherapy is going to do the job, and we could maybe spare a patient the chemo. At the end of the day, it's also important to consider, of course, what a patient prefers. And this is an opportunity for shared decision making so that a patient can help decide for themselves. Would they rather maybe err on the side of a little too much or a little less than might be needed? So these are all good options. And at this point, it is reasonable to consider immunotherapy alone, given IV every few weeks, or chemo plus immunotherapy as the leading options, or both very strong options for patients with high tumor PD-L1 levels and no evidence of a driver mutation in their cancer.